Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Hey everyone, welcome back to Air Force CardioNerds, where we fly from state to state, learning from inspiring faculty and fellows, and celebrate the differences which make cardiology stronger. This incredible program is thanks to a collaboration between the American College of Cardiology Pennsylvania chapter, the ACC Fit section, and us CardioNerds. Today, we get to fly to Gainesville, Florida, as we host the ACC Florida chapter to learn from the one and only Dr. Key Park. But first, I'd like to welcome my co-hosts. First off, we have Dr. Zarina Sharalaya, Interventional Cardiology Fellow here with me at Cleveland Clinic and my personal go-to when I need help in a cath lab. Dr. Laurie Mbuntum, IC-bound General Fellow at UT Southwestern, and Dr. Ashley Mohadjer, Interventional Fellow at Vanderbilt University. Zarina, you've been such an integral part of the CardioNerds Narratives Project, and we couldn't be more grateful for your leadership in helping us promote diversity and inclusion in cardiology. Thanks for being such an incredible nerd.
Thanks, Amit. I'm so thrilled to have both Laurie and Ashley with us for this session. Laurie and Ashley, would you please introduce yourselves?
Hey, Laurie, sorry you're muted. I told you it was going to happen more than once.
That is true.
I'm glad it was you and not me this time.
Thank you, Zarina. Hello, CardioNerds. It's a great pleasure to be back to the CardioNerd stage today. I'm Laurie Mbuntum. I was born and spent the first half of my life in Cameroon, that's in West Africa, before moving to the United States in Maryland, where I completed college and medical school, and then came down to UT Southwestern for internal medicine residency. And I loved it so much, so I stayed here for general cardiology. And during my first year of cardiology, I fell in love with the cath lab and everything that we can do in there. And I decided to pursue a career in interventional cardiology. So I'll be staying here at UT Southwestern for that. I'm so excited to be here today, and I'm very excited to be talking to Dr. Park about two important topics, CardioNerds. Thank you.
Hey, CardioNerds. So excited to be back with this awesome crew today. So my name's Ashley Mohadjer. I'm originally from Southern California, and I've essentially taken a tour across the U.S. for my training. After medical school in Southern California, I traded the sun for some lake effect snow for my internal medicine residency at CCF in Cleveland. I then moved south to the swamp to complete my cardiology fellowship at UF in Gainesville. Go Gators! And then I moved here to Nashville, or what sometimes is known as Nash Vegas, apparently, for my interventional fellowship here at Vanderbilt. It was actually during my 3 years at UF that I had the wonderful opportunity to work with Dr. Key Park, who I have the absolute privilege of introducing as our faculty expert for today's discussion. Dr. Park is a Florida native and completed her bachelor's degree at the University of Florida. She went on to medical school as well as completed a master's in translational science at University of Florida College of Medicine, where she stayed on to complete internal medicine residency, cardiology fellowship, and interventional training. Dr. Park is currently clinical assistant professor of medicine and an interventional cardiologist at University of Florida and the Malcom Randall VA Medical Center in Gainesville. She has a special clinical research interest in women's cardiovascular health, specifically the association of pregnancy complication and long-term cardiac risk. Dr. Park started the first dedicated women's heart health clinic at the University of Florida with a focus on postpartum cardiovascular risk modification. She has received numerous awards for her work in the cardio-obstetrics space and is currently serving as co-chair of the ACC Cardio-Obstetric Work Group. On a personal note, Dr. Park was my faculty mentor during general fellowship and really encouraged me to pursue a career in interventional cardiology. I may or may not actually still have a pair of her old lead cath lab glasses that she gave me in general fellowship. We have worked on research together. We've taken semi-call and attended resident dinners for aspiring women in cardiology. And we even pretended to cath a fake patient together for her feature piece in the ACC Heart of It series. In each instance, she was not only an incredible resource, but full of good advice and also incredibly fun to work with. So Dr. Park, welcome to CardioNerds.
Thank you all so much. And Ashley, I really appreciate that really nice introduction. So thank you all.
I remember exactly about a year ago when I was deciding on pursuing interventional cardiology training, and I watched that particular video, The Heart of It with ACC. And I was just so inspired by your passion, your dedication, and your selflessness. You going from the NICU to the cath lab and pumping, and it was just incredible to see and very inspiring. I knew I was passionate about the cath lab and all that we can accomplish in there, but I was a little bit worried about my ability to integrate, cardio-obstetrics that I had just gotten interested into, interventions, as well as family life. Watching that particular video gave me so much hope and courage. So how do you do it? Just tell me how you got to where you are today.
Thank you, Laurie. And it's really very kind. I had a lot of mixed feelings about making that video to begin with. But I started off my path, loved cardiology, quickly fell in love with procedures. I still to this day just love the cath lab. Occasionally when we don't have fellows and I get to do cases completely by myself, even diagnostics, it just makes me smile. And so I knew my path was with intervention. And then when my son was born very preterm during my interventional fellowship year, things took a little bit of a turn. I think so many of us are very type A, very driven, very focused, which is great. But in my case, my experience with my son sort of had me sort of recalibrate things and look at, where my priorities were. It was kind of a turning point for me. And it also sort of started my path in cardio-obstetrics. So my path in that field was actually driven by realizing that there was a very strong association between pregnancy complications, such as preterm birth and preeclampsia, with long-term cardiovascular disease. And I just found that association to be really fascinating and something that a lot of cardiologists just don't know about. I also had a strong passion for women's cardiovascular disease, having worked with some mentors, including Dr. Peen in microvascular disease. So a couple years into my faculty position, I wanted to start a women's clinic to focus on a lot of these topics. And I realized through that there really was nobody who was doing cardio-obstetrics. And once folks find out that you're doing women's cardiovascular disease, a lot of these patients just sort of end up, being referred. And for me, it was really fascinating because it's really been a sort of really burgeoning field. There's so much about cardio-obstetrics that we don't know. Most of us are not trained in it. And so for me, it's been very exciting to learn more about the field, connect with others, overlap actually with topics in interventional cardiology, funny enough. I just gave a talk on transcatheter interventions in pregnancy, so they do get to overlap sometimes. And so it's been, it's really been very exciting for me. I wake up every day just kind of ready to go and look forward to whatever either the lab or clinical practice may bring. So it's a little bit of insight into my path to kind of where I am at this point.
So, Dr. Park, knowing someone's risk factors for heart disease is very useful. It helps us reclassify our patients into low, intermediate, or high risk categories. Women, in addition to being more affected by our traditional risk factors for cardiovascular disease, have risks that are specific to them, such as pregnancy outcomes. Why do you think screening for OBGYN history for cardiovascular risk, why is that important, and who should be responsible to assess these risks and implement prevention strategies, as some of these women are sometimes, lost in the healthcare system after delivery?
Yeah, so I think there's a couple important points, and it's a good question on multiple levels. So I think if you think about these women, they're often young, otherwise completely healthy looking women. And pregnancy, because of the hemodynamic changes and all the sort of metabolic things that we talk about, really is sort of nature's stress test. And so, I personally think that pregnancy in some women forces clinical manifestations of underlying predisposition to vascular dysfunction. And so these women either have preterm birth, preeclampsia, whatever gestational hypertension that may occur. And then interestingly, a lot of those conditions sort of, resolve after pregnancy. But we know from all the data that we've looked at in the last couple of years that even if that condition does not lead to chronic hypertension or chronic diabetes, that those women actually still have elevated cardiovascular disease risk. So if you look at the guidelines between AHA and ACOG, they recommend yearly screening, no matter what complication you had, for BMI, for hemoglobin A1C, diabetes screening, blood pressure screening, cholesterol. So, which to us seems very typical, right? We always screen for those things, but something that you may not be paying attention to in an otherwise healthy 32-year-old woman. And the other thing that you mentioned is sort of what I think are these gaps in care that occur with these women, because a lot of women don't come for regular care at that age unless they go to their OBGYN. So either they're coming in during a pregnancy, they're coming in for a routine women's health screening. And so those are all opportunities sort of, screen for these conditions. So I think the burden of looking at these, sort of screening opportunities is really spread out amongst so many different areas, which is why it's kind of hard to target. But I think, I've given multitudes of talks at my institution to family medicine, to internal medicine, to cardiology, to OBGYN, trying to really target all of those groups. So I think there's a lot of interdisciplinary work that can be done to try and capture these women and hopefully continue to screen them, catch these risk factors early, and then prevent actual occurrence of cardiovascular disease as these women age.
That's great, Dr. Park. So cardio-obstetrics has been a big part of your clinical and research interest, and you spoke specifically about how you got interested in this. What advice do you have for trainees interested in the topic, especially, those training at programs with little to no expertise in the area? And I ask that particularly for female cardiology fellows who have interest in learning more about these issues like heart disease in women and cardio-obstetrics, and potentially becoming an expert in the field down the line, making that part of the career. What would you advise for trainees in terms of learning more about these topics that often aren't taught as in depth as other things?
Yeah. So it's a good question. I do think that, major societies such as AHA, ACC, the OB/GYN societies are making more of a push to integrate a lot of these topics into the major conferences. I think in the long run, we need to incorporate more of this into our standardized curriculum within cardiology. But in the meantime, I think that, if you go to a conference or know of somebody who is working in that area, try and personally reach out to them. That's kind of how I started. To be quite frank, social media actually has helped quite a bit. Hashtag cardio-obstetrics is, sort of caught on, I think, fairly quickly. And that's connected me to a lot of folks at other specialized centers who do similar type of work. And it's really important for us in this area to kind of connect and run cases by each other, because a lot of these conditions we just don't see that often. And so I think as a fellow, if you're interested, just trying to work in that space, if there is someone at your center who has some interest in women's cardiovascular disease, talking to your program director saying, hey, can I rotate with the OBs for 2 weeks or, something like that. And I can tell you the OBs are very, very interested in this. And so if there's any interest on our side, they take that up pretty quickly. But I think just social media, reaching out to anybody in the field and just showing interest, building a regional network, that kind of thing really, really helps.
I just have to say I couldn't agree more. Getting to meet people that are interested in cardio OB and some of the movers and shakers of cardio OB by virtue of the cardio OB series on CardioNerds, I have to say that these people are some of the most passionate about what they're doing. It's like a burning fire, and there's really sort of like a mission behind that, to take care of young women with cardio-obstetric disease. But Dr. Park, I have to say, between being an interventional cardiology fellow a dad, and a cardio nerd, I feel like I'm hanging on by a thread every day. Of course, don't get me wrong, I'm loving every moment and feel privileged to have each of these in my life, but it definitely is busy. You had a thriving career as an interventionalist. You balanced time with family and somehow still became such a cardio OB boss. And I think your Twitter handle says it all. Cardio PCI mom. It's very on point and descriptive. So tell me, how did you do it? And what were the steps involved in becoming a co-chair of a major society working group?
I made that handle in 2 seconds and it's like stuck with me forever. So it's just hilarious that you say that. But yeah, I mean, I think for one, I think that most cardiologists, again, being sort of type A driven people, we're very hard on ourselves. We're human beings. We're not robots. And so you have to have a little bit of grace and understand that, we are getting constantly pulled in different directions. And that you're not going to be 100% at everything all the time. I know for me, when my son was very, very little, he still had some health concerns or whatnot. So, my focus was just sort of all in on that. And then as he got older, I sort of shifted things and also had solidified a lot of my advanced, coronary skills, and then started learning structural, and then more recently doing CTO. And then at the same time, sort of developing my, cardio clinical practice. So I think, just understanding that, that's why I really hesitate using the word balance. I think integration is a better word, because balance just implies that you always have everything perfectly aligned all the time, and it's just not doable. And I think it's also important to, keep your family and your friends sort of on the same page about what's going on with you and your career and your life and everything, so that they understand. For instance, when I went through my promotion process, I don't think I saw my husband for 3 months. I was buried in my office doing this packet. And I said, this is just what I need to focus on right now. I will get through it. And then, I'll be back. And then I think I took like a 2-week vacation after that. And I just said, I'm done. I'm back, and I think keeping everybody, kind of aligned with the plan, helps. My 7-year-old, I can tell you he's getting to the age where, he kind of is questioning, like, it's the weekend. I've just all call this weekend. It's like, Laurie, as soon as he sees me in scrubs, he's like, oh, she's going in, but I'm very upfront with him. I tell him why I'm going in 7-year-old terms. He's very interested. I said, there's a blockage. Somebody's feeling uncomfortable. I'm going to try and go help them. And, I think he's old enough to understand that. It's also, I think, making, priorities. So certain days, I know that I still have academic work to do, but I choose to come home earlier, have dinner, and then catch up on everything, after my son goes to bed. I had to leave at 5:30 a day because I had to come home and cut my son's hair because he has picture day tomorrow. And he would not go to school tomorrow if I didn't cut his hair. So that was my priority for this afternoon. But, I'll make up the time elsewhere. So I think it's just prioritization, and just, cutting yourself some slack, to be honest. We're not robots. We're human beings.
It's so great to hear you say that, Dr. Park. And it really resonates with me because it's definitely not a balance, and we definitely won't be there and be at our 100% for every domain in our life every single day. And so I think it's so important to come to terms with that, but then also be able to set boundaries and say, look, I'm going to make it to my son's haircut, or I'm going to make it to my son's swimming class on Sundays, or, as an example. And
right.
I think both Dan and I are guilty of reviewing angiograms with our kids. and there have been times when my 4-year-old dude, he'll say, oh, Papa, you have to go to work. Why do you have to go to work? And now he's starting to conceptualize, oh, Papa goes to work to help people. Right. And sometimes he says, Papa has to go to work to make money so I can get presents. But we're working on that one too.
Not untrue. Yeah, actually when my son was 2.5, one day I had to stop by the lab before dropped him off at daycare, which was on the same campus. So I drove by, and this was pre-iPad, pre-TV. So like the cine was like the first like screen he actually ever saw. So I get it. It's just part of who we are, I guess.
That's awesome.
Yeah, I can definitely relate to all those comments about the kids. And there's like a lot of stages from my son being 2 when I started internship to now him being 7 and understanding a little bit more about what I do. It's definitely a challenge. But going back to our cardio OB, maternal mortality has been steadily increasing in the United States over the last couple of decades. And that is despite, all the progress that has been made to improve the OB outcome side of things. And cardiovascular disease account for the majority of these maternal deaths. And this is due to many factors. And as you have pointed out in one of your write-ups, some of the women have inherently acquired cardiovascular disease before becoming pregnant. And they eventually become pregnant and they're at higher risk for these cardiovascular outcomes. So what do you think our role is as cardiologists in the fight to reduce maternal mortality?
Yeah, so that question could probably be like 2 hours in itself because it's such a broad topic.
I gave a whole talk about it.
Yeah, no. So,
Well,
yeah, I think one of the biggest things is just education, both on the sort of chronic level and also the acute level. So I've heard, and I think we've all seen in, the press and literature, these stories of these women coming in who are postpartum. They come in with shortness of breath or, some of those sort of non-specific complaint. And, they're seen by an ED provider who doesn't even know that they just had a baby, which, leads to a whole different differential diagnosis. So I think education is really key. I think access to care. I think we need different models to support women in the peripartum stage. And having been a mother myself, when you first have a baby, your whole world is that child. And you deprioritize your own health concerns, right? Like you'll always take your baby to the doctor, to the pediatrician, but your health is very far down on the list. So I think that, things like innovations such as telehealth, I know there's several programs to do a lot of postpartum hypertension follow-up and things like that are really innovative, and we need more sort of out of the box, solutions to that. Insurance coverage postpartum in this country is just suboptimal. There's legislation that's being put through to try and improve that. So there's no real short answer to your question. If I had to pick, any of those things as a priority, I would say that it would be education, because we can't really start to make true differences, in our field in this area unless we all understand that there are significant issues. And, despite healthcare being as good in this country as it is, our maternal mortality is terrible. And as you said, cardiovascular disease is absolutely the leading cause of that. And so it's been interesting working in the cardio OB space, because it's great that you become a resource, at your own institution or even regionally for referrals and things. But at the same time, I almost wish I wasn't needed. I almost wish that everybody had sort of, generalized knowledge about these women. Cause, it's just part of what we see.
I'm thinking back to an individual who's probably pushed the envelope the furthest in terms of women's cardiovascular health. Nanette Wenger, who's really modeled all the different ways that cardiologists can get involved and improve the lives of women dealing with cardiovascular issues. And she, I think, just said it the best. It was educate. I have to remember this. No, it was investigate, educate, advocate, legislate. Just thinking about all the different domains that we can have influence, both within our individual microcosms, but then also further beyond, and I look to you, Dr. Park, in terms of everything that you're doing to push the envelope and, with regards to investigating and advocating. And, we had the pleasure of learning from Dr. Bond, an episode that's going to come out later in terms of, pushing forward legislation and speaking at the White House and moving, all of these domains, working in all of these domains, because I think it's so important that not one single act is sufficient. You need big teams and you need to be active in these different domains as part of the team.
Yeah, absolutely.
speaking about these different domains, and thinking about sort of different ways that, we can, address some of these issues. Dr. Park, where do you see the field of cardio-obstetrics going in the next few years?
So I think that, I think it needs to become more mainstream in terms of education. Like I said, we're actually working with ACC to develop a dedicated event just on that topic alone, which I think could probably fill a whole week by itself. I think that one of the things that I find really interesting, again, sort of on the education note, is the role of educating subspecialty fellows on various cardio-OB topics. So for instance, we see arrhythmias in pregnancy all the time. Rates of acute MI in pregnancy are increasing. Women will maybe need support for, peripartum cardiogenic shock. It really sort of spans the whole spectrum in cardiology. So I know I sound like a broken record, but I think education, is really, really sort of the key. And then also, furthering collaborations with ACOG and SMFM and the maternal fetal medicine societies, because, they are also heavily invested, obviously, in the health, maternal health, of course, as well as the fetal outcomes. And, they're very hungry to work with us and learn more and collaborate. So I think sort of fostering, highlighting centers that have cardio-obstetrics programs, trying to build networks, development of registries. So the HOPE registry, being spearheaded out of Kansas, I think is going to be really big, because one of the biggest hurdles that we have in this area is just lack of data. And so we just need to understand better how to treat these women, and clinical trials in pregnant women often just, especially in the drug therapy and interventions and cardiovascular, they just don't exist. And realistically, they probably never really will for certain types of conditions. So we just need sort of group power in terms of calling data and seeing what that shows us, and developing, best practices based on experience. And that's, I think, part of what's really key to helping these women.
Yeah, thanks, Dr. Park. And, there's pushing the envelope in sort of the national and international level, but practically speaking, we also have to make change within the four walls of our own hospital. And you've been able to do that by opening up a women's heart center there. So I want to ask a quick question, and I'm thinking about people like Dr. Danny Cruciat, who is in the audience right now, who graduated from MGH and is passionate about cardio OB. And like her, I think there's going to be a legion of providers who are passionate about this topic and want to create change in their environments around them. So, what was involved in mobilizing the local infrastructure and administrative support to create a heart clinic that would reach across the aisle and collaborate with everyone else involved, like obstetrics and the other subspecialties?
Yeah, so it's a good question. Full disclosure, I did not have a plan. When I started as faculty, I actually had a half day of reading echo, which, to be quite honest, when I decided to open this clinic, I went to my division chair at the time, and I said, I want to do this clinic. And she knew my background and research and everything, and she was fully supportive. And when I started the clinic, actually, and still to this day, unfortunately, us in clinical practice, we just don't get as well compensated for doing that type of work versus doing procedural work. And so, but fortunately, the division was very understanding. And so, at first I just said, I just want to see women. I don't care whatever, kind of things. And, the interesting thing about having a women's cardiovascular disease clinic is that, it's not hard. Like, I did not have to really invest much into PR or anything. Women, they're really the drivers of healthcare. And you will have women who come in, they bring their sister, they bring their mother-in-law, they bring everybody in their book club, so it's not hard to get these women to come, and part of it has just been incredibly rewarding, especially with the microvascular disease patients that we've seen, who I've had patients who have had 10, 12 diagnostic angiograms. I mean, it's just insane. And so they're very eager to come see somebody who really specializes in that area. So and then the cardio-ob component just sort of came along with that. I happen to be very lucky at our institution. We actually have a maternal fetal medicine faculty member who also trained in internal medicine. So, it's clearly, sort of similar background, similar training. We work extremely well together. I have a great congenital partner here. So we had all of the elements there. It's just a matter of sort of putting it together. And so for me, it's just putting the pieces together. But Danny and I have talked several times. I actually just got her set up already. She hasn't even started yet, and I already referred her a patient down in Tampa. But she's off to a great start, and it's really exciting. It's a point about networking before. I think that's just sort of how you do it. You just reach out to people and say, "How did you do it?" And I'm still reaching out to my friends at other centers. My good friend Kate Lindley at WashU. I'm probably going to sit down with her at some point and say, how did you take your program to the even more next level? Because there's always more that you can do. But I think it's also important to understand what are the strengths of your institution. And having visited other women's centers, they all can vary a little bit. Some are a little bit more research focused. Some are a little bit more into a certain X and S condition than versus others. Some have more cardio-ob than not. So I think it's important to understand your environment and what's going to work well there as well.
Thanks, Dr. Park, for that insight, particularly into starting a women's heart clinic. It's definitely something that I hopefully aspire to do in my career at some point. So, and then in terms of the microvascular disease, that's something that Amit and I have been really fortunate to learn more about that in the last year from new additions to our staff, Dr. Ziada and Dr. Raphael. They've just been, it's amazing, the whole world of microvascular disease and the tremendous benefit you can bring to your patients if you just address this issue. So one thing we ask a lot of our guests is, did you always know that you were going to be a cardiologist?
Yeah, pretty much. So I actually, my father has some history of heart disease. And so I think sort of not uncommon where we have some, exposure personally. And then when I was going through medical school, cardiovascular physiology was by far the hardest course that we had, but, I just fell in love with it and hemodynamics and really knew that I wanted to do cardiology, and then focused on that when I was an internal medicine resident. And then when I was in residency, I worked with one of our interventional faculty, who's now my colleague. And at the time, I remember thinking it was amazing because we would have meetings in the cath lab. And so I just loved going down there. And part of my research actually was looking at coronary angiograms for patients who had undergone heart transplant. And so, I started learning how to read angiograms when I was a second year resident. And so, for me, just being in an environment, I love doing procedures. Actually, towards the end of my medicine residency, I switched out, I think, half of my ward rotations for ICU, because I just loved being on call, just being up 24 hours, doing procedures, A-lines, intubation, whatever you could think of, I would get my hands on. And so I knew pretty early I wanted to do cardiology, and pretty early that I wanted to do interventional. And unlike, unfortunately, what I've heard from many folks, many trainees and colleagues, I had an incredibly supportive program. Folks just kind of never mentioned anything about my gender. They just sort of expected me to become, to join some, their interventional ranks. And there was never any question about, can you have a family and can you be an interventional cardiologist? And that still continued to this day with all of my faculty and everyone I work with. So I was incredibly supported in that decision, and also in the setting of my in my interventional fellowship because I did have a pregnancy complications. But I know that environment is not uniform across everywhere. And unfortunately, women do often face challenges when they are considering interventional. But like I said earlier, I think that it's all doable. You just have to sort of have the right expectations. But it definitely can be done and be incredibly fulfilling and worth, every minute of it.
That is very, very nice to hear. I too had a great supportive environment last year when I was contemplating, pursuing career in interventional cardiology. I didn't know that I wanted to do it when I started fellowship. I was going to be a preventative cardiologist, but then I spent 2 months in the cath lab, and that's where I wanted to be for the rest of my fellowship. But when I was thinking about it, I had a lot of reservation. I call myself the rate limiting step to that decision. Everybody else saw my potential, but I had 2 kids. I was a woman. I was a Black woman. I was a woman in a very traditional marriage. And I just saw a lot of roadblocks for myself, and I just didn't know how I could make it work. So I love how you use that term. You don't use the work-life balance because there's no balance, but there's integration. So what advice you would give to medical student residents who are contemplating a career in this field but are worried about, balancing or integrating different parts of their life?
Yeah, so it's kind of overlaps a little bit with what I said earlier, but I think that just understanding that certain components, for instance, interventional fellowship is just, no matter how you cut it, is incredibly demanding. And so I think that just understanding that, for that year, you're 100%, 150% really just in it. And so understanding that, at other times, your family, may become more important. One thing I realized probably just in the last year is that, when we think about our jobs, we always give 110, 120, 150%, right? And then I thought about it. I said, why does it feel like I'm only giving maybe 50% to my family? It's not fair. But I think it's best if you look at it that sometimes you're giving 150% to your family, and sometimes you're giving 150% to your job. It's not always, evenly distributed. And so I think just keeping that in mind, one thing is it's very practical, but is incredibly helpful is that, in your work or your personal life, delegate things. So, there's certain things, that if you don't need to do it at work, don't do it. At home, we hired a cleaning service a couple of years ago, and it was life-changing. At first I kind of was like, oh, I don't want to pay for the cost of it or whatever. And then, I said to myself, it's not that much money. And if I get 3 hours of my life back every week, it is 100% worth it. Now, I know as trainees, I'm not saying everybody has like the complete finances to do that. But by all means, if that's possible. And also, really just don't be afraid to ask for help, with friends, with family. I think sometimes, especially women in our field are afraid of asking for help or asking for coverage or something because there's a perception that we will be seen as somewhat weak. And I will tell you, I feel like the field is becoming much more progressive, and that these types of work-life issues are not just something that I hear from women in our field. I hear it a lot from male fellows as well and male faculty. And so I think that, I think our field's changing. And I think that, part of, being a wife, a mother, an interventional cardiologist, we're in a more contemporary time period where it is again doable. But just understanding that seek help. You don't have to do everything perfectly, right? So if your house, is not 100% tip-top shape, who cares? So just kind of understanding all those limitations, and then just the thing that drives all of this really, really is just passion. It's just incredible amounts of passion for what you do. because that's what makes all of the challenges really sort of, worth it in the end.
Wow, Dr. Park, that was incredible. And, I think you're so right that, on one hand, we have to kind of give ourselves a break sometimes. But I couldn't agree with you more in getting more help at home so we can really do anything that we can to spend a little bit of extra time with the kids. And I think it's not necessarily how much time, but it's like the quality of time,
Right.
You're there, screens are off, you're 100% with them. So we got a cleaning service also, but I will say before we did that, I bought my son this like toddler cleaning kit with brooms and mops because I thought maybe I could kill two birds with one stone, but it definitely backfired. So I wouldn't recommend that to cardio nerds out there.
He didn't take it up, like just go after it.
No, now I just have to like pick up the brooms and mops for the floor.
That's awesome.
Thanks, Dr. Park. That's all very great advice. And one thing I did want to ask you also, JAMA had released an article earlier this year looking at the timeline of childbearing among physicians as compared to non-physicians, basically indicating that physicians delay childbearing, particularly those in subspecialty fields. So what's your take on this, and what would you like to see change to facilitate more support with all of this?
Yeah, so I think, if you look at the intersection of average childbearing age with the timeline of our training, it's exactly like this. And I think I've given a talk where I made some kind of figure of that. And I think maybe sort of in essence, what you're asking in a way is, this age-old question of like, when is a good time? Like you get that question a lot. And I've heard so many different variations of how to answer that. And, I think that it's just so individualized. I think that, nowadays, our decisions about when to have children are so different than they used to be. And, people should make that decision when it feels, appropriate for them. You also, there's all kinds of things, there's egg harvesting. There's all kinds of different technology too, and things to take advantage of. But I think from a support standpoint, I think that, as I mentioned, in terms of the field progressing, I think that our mentality around training and leave needs to change. We do not have uniform parental leave policies in this country. It's all institutionally dependent. People rely on FMLA, but, there's unpaid leave. It's completely all over the place. And particularly, it comes up in general training, but it gets even trickier when you think about subspecialty training, because you can't take that much leave in a program that's a year or two. So I know I personally faced that, when I was going through my pregnancy complications. So I think that there needs to be more flexibility in terms of training. And again, not something that just affects mothers. It affects paternity leave too. And so I think that trainees are more in tune to this. I find that more and more trainees of both genders are looking for this, and we're working actually on a little bit on some survey data regarding these topics. But I think that I think training needs to be more fluid and more accommodating in terms of allowing for that intersection to occur. But like you said, it needs to be supported. I think we're getting there. I think it was a year or two they finally started requiring via ACG&E that every institution have, dedicated lactation rooms. I remember when I was pregnant, after I had my son, they literally had just opened a lactation room. I was so thrilled that I didn't have to like hide in the bathroom or something somewhere to try and pump and things. And so it's getting there. But I think more, institutional support, societal support really can sort of help with that. I don't know if I exactly answered your question, but hopefully address some component of it.
That was perfect. Thanks.
Actually, I've got one question from the audience. This is from Dr. Gurleen Kaur. Gurleen is well known to cardio nerds. She is a cardio nerd. She is just started her residency at the Brigham and is entertaining. Okay, as an intern, she's entertaining a career in interventional cardiology. Also interested in prevention, also interested in women's cardiovascular health. So fits right into this group here. So Gurleen asked, Dr. Park, you mentioned always enjoying doing procedures which drew you to interventional cardiology early on in your career. Were you someone who was always great at doing procedures and skilled with them, with working with your hands? If not, what were some challenges you faced early on in interventional training, and how have you evolved since then?
So I would say, having trained other fellows now, I've had fellows who are not so great with their hands. I've had some who seem like they were savants, like they were like came out of the womb as an interventional cardiologist. It's like unbelievable.
Like Ashley.
Yes, absolutely.
Lies.
Yes. Yes. Her middle name is Savant. But yeah, I mean, I personally, I think I was sort of average. I remember when I got hired for my faculty position, I stayed at the same institution, and I got approached about staying on as faculty, I think like the beginning of my third year. And I said, what are these people doing? Like I've never even like really done an intervention with them. Like why are they hiring me? Because they don't really know what I can do yet. But I would say that my skill set was I think fairly average, technical wise, but I think it's, I think that in the lab, I think a lot of what the challenge is this very sort of thing that we talk about in terms of imposter syndrome. This feeling where you're like, oh my God, someone's going to find out that I'm really not good at this, right? And you're always kind of struggling with that. And especially in interventional cardiology, when you're in such a male-dominated field, I think we always feel a little bit like, oh, they're looking at you like, this is a woman. Does she know what she's doing? And I know I felt a little bit of that. And even though I work at an amazing facility and Ashley knows this, amazing people who I'm sure never actually thought this about me, but you think about it for yourself. And so, the biggest thing that I found in order to get over that feeling is just, like I said, 100% every case I could get my hands on. Like I actually started my fellowship a little bit early because I was a research fellow. And so I think the last like 6 weeks, so it'd be like May to June before the new fellows started in July, there was actually no cath fellow, junior cath fellow. So I actually started early, got my hands in, kind of at a really good time. And then, I probably told Ashley this before, but I knew I wanted to do interventional because every time I would go off my cath rotation, I would go into like cath withdrawal, and I would have to like come back to like get my fix, of something. So I'd be like consults and I'd come down and see what's going on. And even now, my days when I'm not cathing, I always go in there and I look at what's going on. So, I think the best way to combat a lot of that, and just to improve your skill set at anything, it's not just interventional. I mean, it's clinical practice, seeing different types of patients, whatever it is really just to get your hands in there. You can't get yourself better unless you're in there and you're making mistakes, and you're learning from those mistakes. And that it's really just a matter of time and number of procedures. And, everybody, there are very, like I joke, but I mean, there are very few people who just know how to do what we do. It's all just a matter of numbers and experience.
Yeah, I think that, skill, like most things, improves with practice. And earlier you talked about having a passion for it and you apply yourself. And that's all very important. I personally think that's some of the hardest things about the cath lab is the decision making, because things are not straightforward. And, you can refine your skills, but you really have to, just do right by your patients and work with a team to get everyone's opinion and, and have that foresight. But just want to circle back. We're talking about savants. If anyone's worked with Gurleen, they know that she is quite the savant. And I've more than a few occasions introduced her as a cardiology fellow because of the incredible work she's been doing. And forget that she's an intern. So, Gurleen, if I know you're here right now, you should definitely continue to think about intervention.
She's like a cardiology. She's like a Mensa, like in cardiology already. Right?
There you go. Exactly.
Gurleen, just another plug for you to do interventional cardiology. But also, just circling back to that discussion, first of all, thank you for sharing that. I think I know myself, I can very much identify with the conversation about imposter syndrome and feeling like people are watching you. And, just really thinking back to times that I became interested in cardiology and intervention and sort of finding myself drifting back to the cath lab, as you mentioned, Dr. Park. So thinking about things that, make us happy, what makes your heart flutter about being a woman in cardiology?
It's a good question. I think all the things I talked about in terms of my very diverse clinical practice, but I think one of the things that gets me most excited is doing things like this, where we talk about things, for instance, like imposter syndrome, that I think is often difficult to discuss. But in the broader picture is, trying to bring more women into our field. We all know the rates of, women in cardiology in general is like horrifically low. Interventional cardiology, it is just abysmal. And so, I've encountered residents who, were very well thought of. We all thought they were going to apply for fellowship, and then, they never interview or apply. And we say, what happened? Did something happen? And they're like, oh, well, we just, didn't think we could do it, or work life, or somebody, said that it couldn't work or something. And I completely respect all those decisions. I want women, trainees to, have exposure to folks who are doing it, and have, insight. And so I think one of, my biggest passions, and something that I'm really proud of is starting a Women in Cardiology section for the state of Florida, along with my, good friend, Lisa Lambracas at Miami. Because, and Ashley, you've been to some of those events. I mean, they're very well attended. Women are so eager to connect with each other. They're looking for role models and mentors and sponsors. And so that's really one of the things that, I'm very, very, very passionate about. And I see a lot of momentum in that area too. So it's very, very, exciting. And, especially being able to connect with all three of you today, it's just, the smile's going to stay on my face for like hours after this, because just being able to hang out with, young, exciting, female trainees, going into interventional is just amazing. And really just makes me so happy.
Wow, this is such an incredible session. And I mean, this whole series has been so awesome, but Dr. Park, I can't thank you enough. CardioNerds itself is nothing without the people that make it. So Zarina, Laurie, and Ashley, thank you for being here, being a part of the community, and always contributing and really elevating this discussion. But Dr. Park, I just don't have enough words to thank you, not just for this session, but people don't know how much support and encouragement you've provided for us in our journey. I remember when I watched that The Heart of It YouTube video, about you and your story, and I was just so touched. I was like, oh my gosh, like I want to get to know this person. It was so inspiring. And I remember it was actually shortly after I watched that we connected. And the words of advice that you had for the broader Narratives in Cardiology series, we really took to heart, and it's transformed, some of the ways that we've designed it. And so thank you for being such a key advisor for that. And people don't realize that the whole CardioNerds Cardio-Obstetrics series really came out of seeing your passion for this field and the encouragement you gave for us to take that on. So again, can't thank you enough for everything you've done for us, for this session. And we're excited to just continue taking inspiration and teaching, and hopefully more of your time down the road.
Absolutely. Thank you all. It's been great working with everybody, and really look forward to your continued work with all of this. So thanks.
Thanks, Dr. Park.
Thank you all.
Thank you.
Thank you so much.